Am I the only attorney in this room? No? Oh, good. Oh, good. Okay, because I was sitting here and I was recalling one of my first days in my Master's of Public Health work. I was sitting in a room full of physicians and dentists and nurses and direct healthcare providers. And it was a large lecture hall, and my professor asked a question, and I gamely answered it. And he said, "You're not a provider, are you?" And I said, "No, I'm a lawyer." And it was as if everybody took 4 giant steps toward the corners of the room. And I said, "But I do not sue providers." And then they all came back, and they were interested in talking to me again. As my research interests suggest, I've got a wide array of interests, but my primary one, there is a theme that unifies all of them, and it is the way that law can be a facilitator of improving healthcare outcomes, but also the way in which it more often than not, intentionally or unintentionally, gets in the way of good health outcomes. So let me tell you a little bit about how I think as a lawyer and how I stumbled into this issue of mercury amalgams. I don't have PowerPoints, I don't have numbers, I don't have graphs. I cannot compete with you folks on that, so I won't even try. Lawyers are very concerned with process. Lawyers are less concerned with outcomes. Many of you, as more scientifically oriented individuals, are very worried, and rightfully so, about nailing down the research and which thing will cause which outcome, and what's a good outcome, and what's a bad outcome, and what's a good treatment intervention, and what's a hurtful intervention. Lawyers, you could get the worst outcome in the world, and lawyers might be very happy because the process worked. So a good example of this is the doctrine of informed consent. There is a process in the law that is very long-standing, and basically it is a process for allocating decision-making in areas of risk and uncertainty. So when there is a decision to be made, and there is risk, and there is uncertainty, the person who bears that risk is supposed to make that decision. And informed consent is rooted in our respect for the autonomy of the individual. And this is, in the United States, we're like manic about the power and the sanctity of the individual. I often teach my class at BC Law School when we're looking at comparative healthcare systems, and we're looking at why does Canada do things one way, why does England do things, Germany, Singapore, and why is the United States so screwy? There are many reasons, many answers for that, but one reason why we are so different is that we value the individual above all. You can go to other countries and it is one for all. In the United States, it is all for one. The individual is paramount, and the individual should call the shots about what happens to that individual's body. So the doctrine of informed consent says, and I'm sure many of you know this, that the provider, in recommending a treatment intervention, should disclose all material information to that individual, and that the individual should, in a voluntary, informed way, if the individual is mentally competent to make decisions, the individual should take all of that material information about the proposed treatment intervention, as well as risks and benefits about alternative treatment interventions, including no treatment interventions, and the individual should make that decision. Now, the actual decision can be absolutely crazy. It can be completely harmful. It can be irrational, if not insane. And lawyers will be very happy if it was an informed decision. There is no insistence in the law that the decision be rational, popular, conforming to the professional's recommendation, and all reflective of majority opinion. So if the individual has material information, makes a voluntary decision without any undue duress, has mental competency to do that, that decision is to be respected, even if the healthcare provider thinks you're doing the wrong thing. So that's an example of where if the process is respected, lawyers are happy, even if the healthcare provider might be very, very disturbed with the ultimate outcome of that decision. Well, I stumbled upon the issue of mercury amalgams when one of my students came to me and said for his final paper he wanted to work on an issue that his law firm summer job had acquainted him with, and basically he worked at a firm in Connecticut, and the firm had represented a dentist who was being disciplined by the state licensing board for discussing the risks of mercury amalgams with his patient. I said, oh, no, Paul, this cannot be happening. That's stupid. Of course the dentist can discuss that. It's informed consent. Everybody knows mercury is a problem. I didn't even know mercury was in fillings. My mouth is probably half mercury. And I said, no, Paul, you're all wrong. That cannot be. And he said, no, the board is going after this dentist and they wants to pull his license because he is discussing mercury risks with his patient. And I was flabbergasted. So I started looking into it more deeply and ultimately, with a colleague, wrote an article about this. In the course of writing the article, I looked at the pressures that are being placed on dentists by the licensing boards, which are heavily influenced by the American Dental Association, and how the nature of the communication between the provider and the patient is in effect being censored by licensing authorities. It was very, very disturbing to me because I am a lawyer and I am trained to protect individual rights, and I am, whether that individual is the patient or the individual is the healthcare provider. Because if nothing else, there should be some freedom of speech, and there should also be the expectation that the provider should be able to discuss candidly the risks that either he or she thinks are material worth disclosing to the patient, or simply discussing the patient's concerns. If the patient cannot discuss this with the dentist, where is the patient supposed to go? So I was very upset about that. In researching this more thoroughly, I started learning more about the problem with mercury. And I realized that, or at least the supposed problems, the risks. From my point of view, I don't even need to pin down these risks. I'm cheering on all of you who are doing the scientific research to really pin this down more thoroughly. But as a lawyer, as long as I know there's a risk, then there is something that needs to be disclosed and discussed with the patient. End of story. We don't need to say, oh, you don't discuss it until you get a p-value of this, or you get a relative risk ratio of that. If there is a risk and it is material, it should be discussed. I realized how hard it is to be an informed consumer, because here I am, an attorney. I deal in healthcare law. I deal a lot with toxic torts. I have my degree in biology. I worked in a lab for several years before attending law school. And I flashed back to a time when my daughter was getting a tooth filled. And it was a rear molar, and my daughter was 6 years old at the time, and the dentist said, and I love my dentist, I respect him enormously, but he's telling me about, you can go silver or composite. And then I said, well, what's the difference? And, he always has, he's good, he makes a lot of money, and that's fine, but he has a tendency to really go with the most expensive, and then you kind of have to talk him down to something else. So I just assumed this was another episode of that. And I said, what is the difference? And he said, purely aesthetic. I said, that's it? And he said, yep, just aesthetic. And I said, rear molar? Yep. I said, okay, go with the silver. I started doing this research now on this issue, and I called him up. It's now several years later, and I said, Scott, those silver mercuries? I heard the wildest thing. I heard there's mercury in them. And he said, oh, loaded with it. And so I thought, Okay, short of being a dentist or, maybe another direct healthcare provider, I'm probably about, as educated and sophisticated as, the higher end of sophisticated patients/consumers. Why was it so hard for me to be informed? He apparently didn't feel any obligation to discuss this with me at the time that we were making this treatment decision, and I didn't know to ask. Now, the situation in many states is that the dentist may discuss these if asked by the patient. But it is very, very tricky from state to state to state for the dentist to decide on his or her own volition, I think this is something to warn about, either because I think it's a real risk, or I want to warn about it just as defensive medicine. I don't want to get nailed in a lawsuit later on for failure to disclose material information. And yet it's really, really difficult to do that. Now, if it were strict informed consent, and I will get to FDA stuff, which is what I said I would talk about, but this all ties into it. Under a typical informed consent lawsuit, here's how it goes. The provider has a duty to warn of material information. How do we measure materiality? Material information can be measured differently from state to state. There are 50 states. It makes your life very complicated. Some states will say, well, what is material, i.e. important, significant, something that would alter the decision properly, alter the decision possibly if the consumer had that information. Materiality is sometimes measured from the reasonable patient's point of view. We project out there into the stratosphere what would the objectively reasonable patient decide. I always volunteer my husband because he's the reasonable man. He can't have an argument about anything. He can't get upset about anything. He's just always reasonable. And I said, we should just replace the jury system with you because you are the reasonable man. So he's a lawyer. He can go with me on that. So you can measure it from the objectively reasonable patient's point of view. You can measure it from the provider's point of view as to what should be material. Most states are going to lean more toward looking to the patient's point of view in determining materiality, just because the notion of informed consent, after all, is rooted in patient autonomy. So we should think carefully about what patients want to know. And some states, or at least in some cases, will look at the subjective patient. So, for example, there was a lawsuit in Massachusetts recently where Julie Andrews of Sound of Music was suing her surgeons for throat surgery that was done on some polyps in her throat, eminent surgeons at Mass General Hospital. And the whole case came down to informed consent. The surgeons had given very full and adequate consent for the normal person, but when your career is tied up in your throat and you are Julie Andrews, perhaps there were some additional consent requirements. The case settled. So there are varying notions of informed consent, but let's say the material information, whatever that is, was not communicated. Then what does the patient need to prove? The patient would then need to prove that had I had that information, I may have made a decision. The lack of that information caused damage. So typical malpractice or negligence case is A, B, C, D, A, duty, breach, causation, damages. The problem in a good old-fashioned personal injury lawsuit is that they are difficult to win. It doesn't really matter. If you are a provider and you are being sued, it is torture for you. It is costly for you, whether this suit is a winner for the patient or a loser. It is a horrible experience to be sued. The only people who have fun in litigation are the lawyers, and even that's a maybe. So, lawsuits are especially difficult to bring, personal injury lawsuits, because of tort reform, which basically creates more and more disincentives for personal injury lawyers to bring lawsuits. And I have no opinion on whether that's a good or bad thing. But let's say a lawsuit goes forward, and it even looks like a legitimate lawsuit. I mean, we've talked a lot today in the past few days about the risks of mercury. It seems to be that there is something happening. There is some strong indication that mercury may cause a problem. Let's assume that the person got mercury in an even more direct way, just drank a glass of mercury, and now has all sorts of neurological problems. The big problem in a lawsuit is proving causation. Because of, you may know about Daubert problems. The Daubert case was a United States Supreme Court case in which the United States Supreme Court said we need to purge the trial court system of junk science. We're not letting all of these wacky expert witnesses come in with all of these wacky ideas about what causes harm. So in order to get a personal injury case from the pleading stage to the jury stage, the plaintiffs need to offer evidence and the defendants need to rebut evidence that is relevant, meaning it has something to do with what you're arguing about or what you're claiming, reliable, meaning that it is backed up by good studies, and many times the courts want epidemiology, and it's hard to find epidemiology just because of the difficulty of conducting the studies, the low prevalence, the kinds of autoimmune diseases and reactions that are just hard to measure. And so all of that can make these lawsuits very difficult to prove, and you have to prove general causation and specific causation, meaning that you have to prove that the product in general is capable of causing the kind of health outcome that you're asserting it caused, and then you have to prove specific causation, which means it actually caused that harm in this specific individual. So those kinds of good old-fashioned informed consent lawsuits are hard to win. And it also assumes somebody has access to the trial court system to begin with, access to an attorney, and those are all kinds of barriers. It's also a lousy way to deal with taking care of patient health. You wait for somebody to get sick, and then you expect them to sue because now they need money because they've got all kinds of health problems. That's not a good system. There should be better ways to prevent these adverse health effects to begin with. Supposedly, we have some of these methods in place. One system, because attorneys love processes, is the FDA regulatory system. FDA, the Food and Drug Administration, regulates biologics, drugs. It also regulates medical devices. And the fillings, the mercury amalgam, the actual mercury, the amalgam alloy, those are all regulated as devices, as are my son's bioprosthetic heart valve, the Band-Aid that's in my shoe. These are all medical devices that are regulated by the FDA. Now, within the FDA, I had to write this down because I couldn't remember it. The FDA is then broken down into the Center for Devices and Radiological Health, and that's then broken down into a number of divisions, including the Division of Anesthesiology, General Hospitals, Infection Control, thank you, Dental Devices, and Office of Dental Evaluation. And then that is broken down further to a number of branches, and so you would be concerned with the dental device branch. And that is then broken down into a number of entities. And lo and behold, we finally reach the Dental Device Classification Panel. Now, when the medical device amendments were passed in 1976, amending the Food, Drug, and Cosmetic Act to make the FDA more proactive in ensuring that the products that actually, the drugs and the products and the devices and the food and the biologics that patients actually came into contact with, that there was some governmental mechanism for ensuring that these items were safe and effective, to keep our patients, to keep our consumers, to keep ourselves safe. So of 1,700 generic products they are broken into various categories of products and then consigned to different expert panels, which then look at the products and make recommendations for classifications. So dental products are then sent to the dental device panel, and this is a panel of experts, predominantly dentists. It is supposed to have input from other disciplines as well. And this panel will look at all dental devices and make recommendations about how it should be classified. There's basically a 3-tier classification system for devices: Class 1, Class 2, Class 3, very sexy titles. Class 1 means low risk, low need for FDA oversight. So Band-Aids are there, tongue depressors are there, dental mercury is there. I thought, no, this was another no. This is wacky. No, it is regulated as a Class 1 product. And basically, Class 1 products are subject to general controls, and the entity being regulated is the firm that is manufacturing, or the item is being regulated, but the person who's worried about that is the firm that is manufacturing or distributing product. So not the dentist, but the entity from whom you're buying your supplies. So Class 1 is very low risk. The FDA panel looks at the intended use and the probable risks and the probable benefits. And if the risks are low, then the oversight is going to be low. That makes sense. It's rational. This is supposed to be a rational system. Although I cannot figure out why dental mercury is right next to the Band-Aids. I haven't figured that one out. Class 2 is a higher level of risk. There's some concern. And so in addition to the general controls that are used for Class 1 products, which is just basically, be careful about your labeling, use good manufacturing practices. Could you let us know on an annual basis that you sort of reviewed what you're doing? Could you list the items with us? It's not purely bookkeeping, but it's not heavy-duty regulatory oversight of Class 1. Class 2 is saying, you know what? A little bit more of a risk. So we need some more oversight. And for a brand new product, a manufacturer would have to submit a PMN, as in pre-marketing notification. And it's saying, here's what we're going to do, here's what's going on, and the FDA has to sign off on it before that product can be marketed. Unless the item was on the market before the 1976 medical device amendments, or was substantially equivalent to a product that was on the market before the 76 amendments. So there are many, many things on the market. Over-the-counter drugs are basically probably the most obvious example of things that are being sold that have never really been tested by the FDA or evaluated in any way by the FDA as safe and effective. Currently, amalgam alloy, with which the dental amalgam is mixed, amalgam alloy is regulated as Class 2. Now, Class 3 is the highest level of classification, and this means it is the highest risk, and yet it is an important product to have. You're usually dealing with very significant health problems. There are some risks in the products that you cannot get around. There is a substantial need for the product, and therefore we will let suddenly I am the commissioner of the FDA, we will let the product onto the market, but you have to get pre-marketing approval, or PMA. And this is a timely, costly process that many manufacturers would prefer to avoid. Class 3 pre-marketing approval means essentially that the FDA is making reasonable assurances that the product is safe and effective. So that's the 3-tier classification system. Now the FDA has has classified dental mercury as class 1, has classified amalgam alloy as class 2, has never classified the two of them together. Many will say, well, effectively the two together are regulated as class 2 because that's the higher classification of the amalgam alloy. Others would say, well, we're trying to get the FDA to regulate both explicitly as a class 2. Some say, well, gee, it's really so dangerous, it should be regulated as a class 3 product. And what effect does that have on anything? Because for the provider, the product is going to go to from the manufacturer to the provider. The burdens are really on the manufacturer in terms of pre-marketing approval, pre-marketing notification. The FDA may impose greater post-marketing surveillance, the need to do adverse events reporting, but as mentioned earlier, that's a very spotty and erratic way to collect data and conduct surveillance. What is the big deal from the provider's point of view and, in my mind, most importantly, the patient's point of view? Well, it seems that raising the classification from class 1 to class 2, maybe even class 3, would be more protective of the patient, right? Because it's a more dangerous product. The FDA is acknowledging that there are greater risks, and therefore the FDA is explicitly committing to take greater oversight measures to ensure that the products used in the marketplace are safe and effective. It has a somewhat counterintuitive impact, though, because as you go up the chain of classification, and as you, at least on paper, make it seem that the FDA is practicing more and more oversight, it becomes easier for the manufacturer to resist any state oversight on the grounds of federal preemption. Federal preemption says that federal law wipes out state law. And sometimes you can have federal preemption by virtue of direct conflict. The federal law requires A. The state law says, oh, no A, only B. It's impossible to satisfy both of them simultaneously, and therefore the federal law will trump state law. But there are other kinds of preemption, known as field preemption, where the existence of the federal law displaces any effort by the state to regulate in that area, and or to have any kind of state law obligations, which can also take the form of a state tort suit, a state personal injury suit. So, an example of a class 3, the easiest kind of case in which to show that the FDA classification preempts state law, and this is all by virtue of another provision of the Medical Device Amendments Act that were passed in 1976. An easy case is my son's bioprosthetic heart valve, class 3 product. High need for it, couldn't live without it, literally. But obviously, if the valve fails, it could be catastrophic. May not, could be, God forbid any of it should ever happen. If there is failure, there is no ability for me to sue for design defect. If the if my car breaks down today, I can sue Ford Motor Company perhaps for defective design of my airbag. But I cannot sue a class 3 manufacturer for defective design because by virtue of the class 3 process, the FDA has made a finding that this is safe and effective. And that's it. End of story. I can't challenge it. I can't ask a court to override that decision. I can't ask a jury to make another decision. I could possibly sue for defective manufacture, which means the valve should have been fine. We all agree that the FDA passed off on safety and effectiveness because it is safe and effective, but there was a glitch in the manufacturing of this particular item, so perhaps I could sue for that. But I can't do it for most problems. I can't even do it for duty to warn because the FDA authorizes, approves the marketing literature, the warning literature. Now, Class 2 is a little bit vaguer, but there is still a very strong argument that if there is a Class 2 approval where the FDA has said, has either passed on, has approved pre-marketing notification materials or has allowed this on the market because it's been on the market and will basically oversee labeling information, other packaging information. They literally look at the size of the font, the color, you know, what language you're communicating this in. If that's all approved, then there's no room for a state lawsuit that says you should have warned me better, you should have warned me differently, you should have told me something more. So preemption becomes a very powerful concern from the patient's point of view, from the provider's point of view, and a very powerful incentive from the manufacturer's point of view because they are the ones that are off the hook. Now, you can see how this up-classification, which supposedly protects the patient, might be increasingly problematic for the patient because it's limiting the patient's remedies in the event that something goes wrong. Does the provider care? Yeah, the provider cares. Because a couple of things. When the manufacturer warns the provider, the manufacturer obviously is going to warn in very technical language. Of course it should. It's communicating with you, an expert, a professional. It should use very technical, detailed language. The law in most states